Good evening. I'll speak briefly about IIH, Idiopathic Intracranial Hypertension. It is a disease of typically unknown cause. However, there are risk factors to it. The typical textbook risk factors are rapid gain of weight, being overweight, being a female in a childbearing age, certain drugs and vitamins like vitamin A derivatives used for acne, antibiotics also treated for several reasons, including skin disorders like tetracycline and having iron deficiency anemia. Also, in special cases like hormonal replacement therapy for female-related disorders. The typical presentation is usually a gradual subacute headache that has poor characterization. There are different characterization of the headache. However, the associated symptoms are typically uh, uh, are typically uh, can be exclusive to raising the cranial pressure, like changing position. Patients will feel the headache more while being in a supine position, and sometimes it can increase also while bending over, and also it is associated with a unique visual phenomena called transient visual obscurations, or TVOs. The patient will describe a sudden brief loss of vision or whitening of the vision or even darkness in the visual field, and this can happen with Valsalva maneuvers or increasing Valsalva, uh, like coughing, sneezing, or suddenly turning the eyes or suddenly turning the head. It is also commonly associated with nausea, vomiting, especially in the early morning. And the last thing that is distinctive in this disease is pulsatile tinnitus, or a whooshing sounds that pulsatile, especially when the headache becomes severe. There are many ways to diagnose the disease. However, the most appropriate method to diagnose the disease is after taking appropriate history and examination of the fundus will typically reveal an swelling of the optic discs, which is called papilledema, regardless of the staging and the severity of papilledema. Sometimes you may or you may not see some restriction of the visual fields, enlarged blind spot by the examination. Typically, it's subtle and cannot be appreciated unless it is severely affecting the visual field and the visual system by compressing the optic nerves, and ruling out the secondary causes is of utmost importance. So neuroimaging is the best next step in such a case before attempting measuring the pressure, which is I'm going to talk briefly again later about it. So uh, uh, the the best modality is actually brain MRI with contrast MRV to rule out any intracranial lesion or space acquiring lesion, and rule out vascular thrombosis, especially in the venous system or venous sinuses thrombosis. And hence it's the name pseudotumor cerebri when there is signs of raised intracranial pressure within the MRI with negative lesion or with negative space occupying lesion. So it's a pseudotumor. The next step in the diagnosis after ruling out intracranial compressing lesion, typically we do a procedure called a lumbar puncture, and we measure the opening pressure while the patient is lying on the left decubitus or right decubitus position. And after confirming the raised pressure, typically it is beyond 25 centimeter of water in obese people, And after ruling out any CNS infection by analyzing the CSF, then the patient can be considered diagnosed of IIH. The methods of treatment are variable. There are non-pharmacological, pharmacological, and surgical approaches. The non-pharmacological approaches is typically, if the patient is overweight, is to ask them to lose weight, exercise, and decrease salt intake in their diet. Pharmacological treatment, there is only one FDA-approved drug, which is called acetazolamide. This drug will work as an water absorber from the CSF and decreases the intracranial pressure, and it's been approved, and it's been approved to be effective in protecting the vision. If it is severe and it is pharmacologically resistant, despite losing weight and decreasing the salt and taking appropriate doses of acetazolamide, or an adjunctive therapy like topiramate or furosemide, then sometimes surgical approaches can be considered, and there are 3 procedures that can be done. The first procedure is when there is severe impending visual loss, or aka fulminant IIH, when the patient is at the verge of losing their vision with very bad visual acuity and visual field testing. The procedure is it's a surgical procedure called optic nerve fenestration, when they fenestrate or make a window within the CSF space around a single or double optic nerve to release the pressure around it, or by shunting procedures. It's done by a neurosurgeon. The previous procedure is usually done by an oculoplastic ophthalmologist or a neuro-ophthalmologist, and the latter is done by a neurosurgeon, as I mentioned. Shunting can be done in variable ways. They can use VP shunt or ventricular peritoneal shunt, or a spinal peritoneal shunt. And the last procedure is to do an angiographic. It's an angiographic procedure, which is done by a neurovascular neurointerventionist, which is unilateral, bilateral transverse sinus stenting. Thank you.